Thank you for having me here. My name is Ivan Gabrié. I come from the eye clinic Svijetlost in Zagreb. And I'm going to talk a little bit about the role of anterior segment OCT in decision making in refractive surgery. Now, after Farhad, it's very difficult to come out and show you those amazing transitions and the case reports. So this is going to be more of a philosophical approach to why you should ditch Placido. This image is from Warren Hill's ASCRS topography course, and it's one of the most beautiful images that I ever use for cases like this. The Chinese emperor asked 6 people who are blind to describe an elephant, and they were all touching different parts of him, and each person was giving the correct thing what they were touching, but nobody said it's an elephant, because that's the problem we have in ophthalmology today. We have biometers, we have keratometers, we have Placido, we have Scheimpflug, we have pure OCT, but none of them tell the whole story. So this is why it's very important in your mind to understand that it's not just mindless button pushing, but every instrument has its purpose and its designed use case. And again, this is from Warren Hill, and I love this because it showcases that with the same tool, someone can do something amazing like Farhad. Even using Scheimpflug to track and create the protocols for keratoconus treatments we have today, and you now know that it was not the best technology, but yet you achieved greatness with it. So the tool is not going to be your limitation, but you need to understand closer, because this was supposed to work. Okay, so for us to understand that we have the tools, we can't rely on our technicians to just do the scan and give us a printout. We have to have access to the machine, understand how it works, what the limitation of the machine is, and what the capabilities are. Unless we are the ones making the decision, we are going to go to the lowest denominator, and that's the tech who's just doing the scan for you. So the keratometer, when it was designed, was an amazing tool, and it allowed many, many things. I still know Nick Roos from ESCRS claims that he uses it to check his IOL calcs every day. Is there anyone in this room who really thinks that's necessary or useful? Because, yeah, exactly, Andrea, nobody wants that. It's crazy. Who would do that? The Placido disc is an amazing piece of technology dating back to mid-19th century. But the other name for this is instant topography, and the word instant is so important. As Farhad showed, you know what? The tiny amount of changes while the camera is rotating can create a lot of issues. So instant, it has a reason why it's instant. Placido can be used for many things. Diagnostics, it can be used for tracking, but it doesn't tell you anything about the back surface, or it doesn't tell you anything about the eye if there's any sort of a surface problem. You have bad dry eye, this is not going to be useful. But it's better than Scheimpflug if you're talking about keratometries or instant. What's the problem with Scheimpflug? The standard scan on Pentacam is 25 slices. The 25 slices take about 1.5 seconds to complete. Now, we've already seen that light scatter can affect it a lot, but think about the time. 1.5 seconds. If someone has nystagmus, or if they're moving their eye, or if they're looking just a tiny bit off center, you can get really crazy data points which make no sense. The problem is the Oculus software is so good that it makes a model that fits the data and you trust it. Now, if you in your head divide 180 by 25, which is the eye, and divide it into 25 slices, it comes out to 7. So the Pentacam makes one scan every 7 degrees. What happens between 0 and 7 and between 7 and 14? Software happens. The problem is you don't think about it in your daily life. You just trust it. You trust it because the model it uses is good enough. It's not great, but it's good enough. So a lot of things go unnoticed between 0 and 7. Then we have combined devices using technology of yesteryear, which is Scheimpflug and Placido. Now, those devices offer instant topography, but they also offer a little bit of extra with the Scheimpflug-based pachymetry data and posterior surface data. Those were a stepping stone. Those were better than pure Scheimpflug and better than pure Placido, but they still are based on Scheimpflug, which is reflected light at an angle of 45 degrees, depending on the room lighting, on other conditions. So again, the same problem as before. Then we have the, well, think about this. This is an anterior segment OCT, an amazing device. What are those things on top? Those are little LEDs. Do you know what the LEDs are used for? Keratometry. So we have a €100,000 device which is doing 64 slices of the cornea and making amazing quality maps and diagnosing keratoconus, but when it comes to simple IOL calculations, it needs the LEDs for keratometry. I mean, it sounds a little bit strange. 64 slices? Yeah, because there's time. The 64 slices, they take time. And for IOL calculations, a mistake in K values is going to be a big problem. So even the mighty Heidelberg needs something like instant keratometry. Okay. And then we have this. Thank you. Thank you, CSO. Because it combined the best of both worlds. It combined Placido for instant topography and keratometry with OCT. And it's the perfect mix. You get anterior surface, you get posterior surface, you get pachymetry, you get instant topography, and when there are data gaps in the Placido, it recreates like the Pentacam does for everything else. But that's not, it's not going topometry to topography. Topography comes from Placido, and then when the gaps occur, it uses topometry to reconstruct, which is great. So that's another type of device we see. And then we have Cassia, great device, great for ICLs, but again, it's pure OCT. It doesn't even have the little LEDs for K value measurements. So again, I wouldn't trust it doing biometry. Why anterior segment OCT? We saw some examples from Professor Hafezi, but this is an image of a normal looking eye. The image on the left and the image on the right don't even look similar. They're completely different. The quality of the image, the level of detail, you can tell that that eye is okay, but everything else is software. Here, on this eye, you can basically go and look at the individual little parts of the cornea. But how does it look in daily practice when you're dealing with a case which is a little bit more difficult? Okay, this is a cone. Everyone knows it, everyone sees it, and you have some scarring there in the middle. But the Pentacam, the golden rule for keratoconus tracking, says this cornea is 356 microns thick, and that's a number. Okay. Yeah, that's a number, which is not true. It's 106 microns, because the Pentacam cannot differentiate stroma from epithelium. You basically end up with a person who is waiting for a corneal transplant. You thought you had 356 in the center, you have 106. Tell him not to exert any pressure on himself and go get a transplant. That is why when you use Scheimpflug as your primary way of tracking keratoconus, again, this map and this eye are the same as this. This is what we used to trust when making decisions in corneal refractive surgery, keratoconus, or refractive surgery. I don't understand how everyone today is not ditching their Scheimpflugs and saying, I don't want it anymore. Because the level of lies that you get from a machine and the level of confidence it gives you is impossible. Now, let's see another example. What happened to the other eye of this patient? Yeah, same problem. Horrible situation. He's being screened by a surgeon who has Pentacam for 15 years, being told that his cone is not progressing after CXL. And he came for a second opinion because his vision was dropping. Now, normal case. This is the standard view from the Pentacam. Everything looks great. And this is the standard view on the MS-39. The difference is, I actually trust this map. I actually trust what I see. And I get a beautiful epithelial map. I can tell this person has moderate dry eye because he's got some epithelial thickening in the base. I know he's good for refractive surgery. I don't have any issues. I don't even screen with Pentacam anymore. I know there are some MS-39 users who still do Pentacam. I know one. I know you threw it away. I am in the same camp. I don't trust it anymore. Every single ectasia we've ever had was screened with a pentacam. Now, let's look at something a little bit more interesting. This is something that Scheimpflug could never image. This is a partially created lenticule. The patient moved during the cut, the vacuum didn't release, and this is maybe 3 minutes, how long it took for me to get from the OR to the MS-39. And a decision was made at that point, hey, this is not extractable, but let's see how it looks. You could never image this with Scheimpflug because you would just get a big reflection. Now, using the power of software and Versace's brain, we have the applanation-like view, which is very, very difficult to understand because sometimes you think you got Baumann undulations, but you just got epithelial irregularities. You need to fix that. Yeah. Anyways, you can actually see the separation that the bubbles created on the lenticule, and you can see that it's a biconvex shape. So, you know, the ones who know. So what did we decide? What do you do with a patient like that? Well, using the magic of CSO software, we took an image 24 hours after surgery, and we took the image from 1 month before the attempted surgery and compared the K values, the topography, densitometry, not densitometry, he promised to build it. He promised he's going to make something. He said, I can say it. Anyways, look, using the MS-39, we could make a conclusion that this eye is almost equal to itself a month ago. So 24 hours after surgery, we just did PRK without any other wait time because you could have reliable data points. No wait. Let's see some other decisions that we can make with this. And this is not really working well. I think you need a new battery. Okay. This is an amazing piece of tool that Versace built with Dan Reinstein. If you click on it, you can get the either the flap thickness or the geometry of the lenticule that's extracted. This was a cylindrical case, so you can see that there's thickening on the oblique axis. So you can not only track what you see, it can kind of simulate the shape of the extracted lenticule, the shape of the flap. It can help you understand what's going on with the patient. But what about when you have something left inside, which, you know, can happen? This is really not working well. Okay, this is the image of the retroillumination from Osiris-T, also called Pyramis. This is epithelial ingrowth in a pocket of a lenticular case, and you can clearly see it. You can clearly see it on topography. You can clearly see it on the normal view, but on the applanation-like view, you can really appreciate how thick and nicely shaped it is. Anyways, once you take it out, you can do it 3 days after. You can actually check on the difference maps. Now, imagine doing that with Scheimpflug. First, it couldn't measure because you would get light scatter. Second, you couldn't track the same position because it's very difficult. And third, you could never get that beautiful view of showing the patient, okay, you see this is the epithelial cells they got in, we're removing them, and then you can show him the day after, look, we removed everything. It's such a great tool to have Phoenix in your office to show the patients what you're doing, how you're making the decision for them. This is the same eye, and if you look at the applanation-like view with the 3-day difference, it's beautiful. You know you've done a great job, the patient is happy, you are happy, and you can print this out to them so they know you've solved the problem. Hey, I print it out for them every single time. This is a case where my colleague was doing lenticular surgery and she used a very sharp tool, poked a hole, and left a little fragment of the lenticule inside the space. You can see here on Osiris the little scatter that's created, and you can see the little lenticule fragment there on retroillumination. Let's try to find it on MS-39. Oh, here it is. Without using applanation view, we could never see it because it was so tiny. But the applanation-like view allowed us to image it. I took the image printed from MS-39, I just circled it, I went in with a smile hook, took it out, it was less than 40 seconds of work for me because I had the tool to show it. And this is the image 10 minutes after the extraction, when the contact lens is on the eye. You can see the little hole where the epithelium thinned itself out to compensate for the internal little thing that was left. And that's it. But what would you use when it's important? This is a scan from MS-39 and the aberration report on MS-39 and the CSO software versus the same report from the Scheinflug thing. Well, this was actually my father's eye. He had LASIK for oblique astigmatism, and there was a discussion in our clinic, what lens should we implant? And my colleague who believes in Pentacam said, no, we can't put any sort of premium lens inside. Look at the Pentacam, look at the aberrations, look at everything. It's never going to work. And I looked at the CSO data. And we calculated the lens using the ray tracing function on the Phoenix software. And I think this is a premium IOL. So you know what we chose and what we trusted. When it comes to trusting your devices, you need to know the basics, how they work, why they work like that, and get the most out of them. Okay, thank you.